Hello, everyone, and welcome to part 2 of our lecture on Chapter 8, Substance Abuse and Mental Health Assessment. In part 1 of our lecture, we talked about alcohol use assessments as well as some brief assessments that will incorporate other assessments of substance use. And in this second half of our lecture, we're going to talk more specifically about the mental health assessments and screeners that are available to you. So to start, I want to talk about depression because mood disorders are the most prevalent mental disorders in the United States, with about 6.7% of adults and 11.4% of adolescents aged 12 to 17 experiencing major depression. And major depression is characteristic of multiple mental health and comorbid disorders, so it's important for us as clinicians to thoroughly screen it for it during any initial assessment. And similar to initial screening inventories and the substance use assessments that we were doing, that we talked about in part 1, there are multiple screeners that you can use to assess for depression. One of the most common ones is the Beck Depression Inventory, which is in its second edition. It is oftentimes just called the BDI, which is a 21-item scale that assesses depressive symptoms that may be affective, cognitive, or behavioral in nature. And the BDI is really great if your agency can afford to use it, because technically you have to pay for every administration of the BDI that you give, and clients are supposed to be re-administered the BDI every 2 weeks. So if you have 35 clients and you are having them take this assessment twice a month, and each assessment costs money, it adds up very quickly to use the BDI. But it does have great reliability and validity, which is why people continue using it. We also have the Children's Depression Inventory 2, which is used in children and adolescents between the ages of 7 and 17 to screen for depression. And it includes 2 scales and 4 subscales that investigate the emotional and functional problems associated with depression around negative mood, negative self-esteem, ineffectiveness, and interpersonal problems. And the CDI is one of the most thoroughly researched of all instruments designed to measure depression in children. And although it was developed primarily for research purposes, it has been used increasingly for clinical purposes because of the lack of effective instruments in the field for adolescents. And there are some shortened versions as well as parent and teacher report versions of the CDI. We also have the Geriatric Depression Scale, which is a 30-item yes or no tool that effectively differentiates between older clients with and without depression. A shortened version of the scale with 15 items also exists if you want to shorten it or have less time with your clients. But the Geriatric Depression Scale focuses on the affective and the cognitive symptoms of depression, because items that assess somatic symptoms of depression have been largely excluded because they do not detect depression as well in older people as they do in younger populations. And we also have the Hamilton Depression Inventory, which is a commonly used 23-item scale that can differentiate well between clients with varying levels of depression. The HDI provides a relatively pure measure of melancholia, which can be helpful in identifying individuals who may benefit from antidepressant medications. So you can see even in this list, and similar to other assessments that we've talked about, there are some similarities in our assessments of depression, but what they do in the utility of those assessments will vary and can be tailored to our clients. So if our agency has the money and can afford the BDI, that might be good. If we're working with children, we want to use the CDI. If we're working with a geriatric population, we want to use the GDS. And if we really have a client who's motivated to be on medication, we might use the HDI to help navigate and determine if they're going to benefit from that medication. We also have assessments of anxiety and fear, which are important because around 25% of US individuals can expect to experience an anxiety disorder in their lifetime, with about 18% of people experiencing one within any given year. And anxiety should be distinguished from fear because they are definitely different things. Anxiety relates to a significant hypervigilance and avoidance behaviors that are due to the anticipation of a future threat, whereas fear is a response to an immediate danger. So, fear is more associated with the actual threat that someone is experiencing that is there, and anxiety is the way that we are fearful of something that could potentially happen in the future. So, this hypervigilance around anticipated future danger. Our assessments of anxiety and fear are going to be similar to our depression in that we have different ones that measure different things. We have the state trait anxiety inventory, which is a 20-item scale that evaluates state anxiety, which is the intensity of symptoms, as well as trait anxiety, which is the frequency of symptoms overall. And it is the most popular and well researched of all anxiety measures. Though the inventory takes about 15 minutes to complete, scoring can take a few minutes because some of the items have to be reverse scored. So, when you have to reverse score in an assessment, you have to take the score that someone reported and invert it on the scale that's being used in that assessment. So, if you have a Likert type scale that ranges 1 to 5, if a client puts a 4 on an item that needs to be reverse scored, that 4 then converts to a 2. A 1 will convert to a 5. A 5 will convert to a 1. A 2 will convert to a 4, and a 3 will always stay the same. So you're inverting or you're reversing the scale on which that item was initially reported in order to create the final score. Reverse scoring is common on more advanced assessments and screeners because it allows for accounting for the possibility that a client might be just answering the questions without reading them, just selecting the same answer for all questions. And reverse coding will help to identify that and to see how it's showing up for the client. Similar to depression, we also have the Beck Anxiety Inventory, or the BAI, which is a 21-item scale that helps counselors to identify 4 degrees of anxiety, ranging from minimal, mild, moderate, to severe. And it measures the aspects of anxiety that are relatively independent of depression. The BAI parallels the BDI in format. So there is a cost for every administration, and it is supposed to be readministered every 2 weeks, which can be a detriment to agencies if they cannot afford to use the BAI. We also have the Social Phobia and Anxiety Inventory, which is a 45-item tool that investigates the frequency of social phobia and agoraphobic symptoms. And in this context, we're using the DSM definitions of these terms. So, social phobia is defined as having a persistent fear of public scrutiny and expressing anxiety symptoms that will be humiliating or embarrassing. And agoraphobia refers to avoiding situations or places where escape may be difficult and having a fear of expressing panic-like symptoms. So this particular inventory is very specific to assessing the frequency and severity of social phobia and agoraphobic symptoms. And we also have some additional measures for evaluating anxiety and fear, and these are listed in your textbook. Again, similar to previous sections, you really have to figure out which one of these is going to be the best for your client. So some of the examples that they have are questions related to multidimensional anxiety, or maybe a test for test anxiety, mathematic anxiety. There's also some in here for obsessive compulsive inventories or PTSD. There's a fear questionnaire. There are some specific for college students, some that are specific for elderly adults. It's really navigating the database of assessments that are available to determine what is going to be the best fit for your client given their identities as well as their presenting concerns. We also have assessments for anger that can aid in crisis intervention work that we do, as well as increase our understanding of factors that can be related to an individual's anger. It's important to keep in mind that anger is a universal emotion that underlies hostile attitudes and aggressive behaviors. So it's really important for us to screen and assess for it with all of our clients because it can be indicative of different behaviors that could be problematic in their life. The A plus standard assessment for anger is the State Trait Anger Expression Inventory 2, which has a similar format to the State Trait Anxiety Inventory. It is a 57 item scale that explores both state and trait characteristic of anger. And although it was initially developed for research purposes, it can be helpful in counseling situations by providing the format for how to consider the different dimensions of anger. So, how it shows up in the client's life, the different ways. Is it more active? Is it more passive? Is it more dominant? Is it more in receiving? What it looks like. And because there's this variation in the different dimensions of anger, sometimes the scores on state trait anger can be a little bit difficult to interpret because it's really hard to understand what these mean in the context of our client, but also the publishing company for this test hasn't published the composition of their normative sample. So it's hard to also ascertain how our client is in comparison to the group on which this assessment was normed because we don't know who it was normed on. And it's also important for us as clinicians to assess for self-injury. In the context of assessment, self-injury involves the deliberate actions of harm that result in physical injury to the self. It may or may not be related to suicidality, so it's important for us to investigate with our clients where this self-injury is lying for them. Prevalence incidence right now vary widely from about 4% to 39% of adolescents engaging in adolescence, and individuals who identify as women are 3 to 4 times more likely to report self-injury than those who identify as men. Self-injury typically gets diagnosed as a major depressive disorder, obsessive compulsive disorder, dissociative identity disorder, schizophrenia, adjustment disorder, or borderline personality disorder, among other diagnoses. And the reason why we see self-injury going into some of these categories is because there is no official diagnosis for self-injury as it exists right now in the DSM. Sometimes self-injury is a part of these diagnoses, but other times it's not. And as clinicians, we really have to navigate with our clients what diagnosis is going to be the best fit for them given their problem with self-injury if it is the thing that they want to work on in session. There are 7 commonly used assessments to measure self-injury. You can see them listed in table 8.2. They are very similar in that they're all going to be assessing self-injury, but the way that they do that is going to be different. And you can also see how the reliability and validity of those assessments change. So some of these self-injuries are going to be assessing for implicit self-injury, so whether or not the person realizes why they're engaging in self-injury, how their self-injury is related to their thoughts as well as their behaviors, whether or not self-injury is related to trauma, or if we just need to assess self-injury in general. And again, you need to use your clinical judgment to determine if that assessment is going to be appropriate for your client given their identities and their presenting concerns. Another assessment of particular importance is the assessment of eating disorders, because eating disorders are classified in the DSM under the category of feeding and eating disorders. And common eating disorders include anorexia nervosa, bulimia nervosa, and binge eating disorder. And as a classification of diagnoses, it is vital for us as clinicians to assess our clients for eating disorders and disordered eating, because this is the area within the DSM that someone can die from their mental illness because they are experiencing problems with the intake of nutrition. So it is vital for us as clinicians to screen our clients at the outset for any possible disordered eating and eating disorders. The prevalence of anorexia and bulimia nervosa tend to develop in adolescence and early adulthood, with prevalence rates between 0.4 and 1.5%. So 0.4% per anorexia and between 1 and 1.5% for bulimia nervosa. Most cases involve individuals assigned female at birth. Around 90% of eating disorder cases are for individuals who were assigned female at birth. Although this statistic should be interpreted with some caution because there's very little research on the experience with eating disorders for those who are assigned male at birth. So it might be that there are more prevalence of eating disorders amongst those individuals assigned male at birth, but we don't have the research to support the experience because no one is exploring it. There are two inventories that are particularly effective for screening for eating disorder or disordered eating. The first of those is the Eating Attitudes Test, which is oftentimes just called EAT, EAT. And it is a 26-item tool that screens for symptoms and related problems of anorexia nervosa as well as other eating problems. And it has 3 scales within it: dieting, bulimia, and oral control. And although it has been relatively reliable across cultures, the EAT-26 is not useful for evaluating eating disorder in sports. So if you have a client who's coming in and it's possible that their disordered eating is related to the athletics that they're in, the EAT is not going to effectively capture this for them. And we also have the Eating Disorders Inventory 3, which is a 91 item scale that assesses eating disorder symptoms and includes a personality assessment of those items as well. So the Eating Disorders Inventory 3 packet is really good if you have personality components that could be leading into someone's disordered eating. The output or the sort of results that you get from the Eating Disorder Inventory 3 packet gives you a symptom checklist as well as a referral form. So if your agency does use the Eating Disorders Inventory 3 and pays for the administration, and it is applicable because there is this personality component for someone, it can be really helpful. It's also important to keep in mind more generally that a lot of individuals who are seeking treatment for eating disorder will wait several years from the onset of their disorder before they ever enter treatment. So early assessment of someone's disordered eating can reduce the length of this period, which is why it's so important for us to assess for eating disorders, even if there's no obvious sign for us to do so. We can use standardized tests to assess the severity of eating problems and to help structure the discussion of the topic in counseling, but we can also use these screeners to help indicate if this needs to be a topic of conversation. And also, to be a clinician in the room with someone who has an eating disorder, it's really important for us to engage in full and honest reporting with our client. So that means that we need to establish a trusting relationship with the client before we ever undertake the assessment so that they know that they can be honest with us. And the final area that I want to talk to y'all about is the assessment of ADHD, or attention deficit hyperactivity disorder. So ADHD is a neurodevelopmental disorder characterized by inattention, hyperactivity, impulsivity, or a combination of these things. And the symptoms of ADHD must be pervasive, maladaptive, and inconsistent with normal developmental expectations in order for us as clinicians to make a diagnosis of ADHD. Those symptoms of ADHD must also have occurred for at least 6 months prior to for at least 6 months and must occur in more than one setting. So this individual must be experiencing some distress or disruption in school and at home, or at home and in their relationships. And it must also interfere with their individual functioning. So how they interact with peers, how well they do in school, how well they do that at their job. Prevalence data shows that ADHD is found in about 5% of the US, or 5% of children and about 2.5% of adults, and is not likely increasing in the United States. Rather, research shows that instead of actually just increasing our diagnoses, what we're seeing is actually an increase in the awareness of the symptoms of ADHD, as well as increasing access to healthcare related to ADHD. Also, in addition to assessing ADHD specific symptoms, as clinicians, we need to use a multimodal approach and assess for the age of onset, duration of symptoms, the extent of functional impairment, and associated conditions of ADHD, take such as talking to multiple people that are involved in someone's life so that we can get the most comprehensive approach and understanding of diagnosis for that client. So instead of just talking with the client themselves about ADHD, you want to talk with the other people in their lives, their teachers, their parents, their friends, their significant others. Get the most well-rounded picture of that person's symptoms so that you can reduce the possibility of misdiagnosis. There are multiple assessments that you can use for assessing ADHD. I will say that in general, we don't have great assessments for looking at inattention right now as it stands in assessment. There are a bunch of different screeners that you can use that will be indicators of possible ADHD, but really a full assessment of ADHD has to be conducted by someone who has received specific training, most likely at a PhD level, and is someone who will go in and do assessments in multiple settings. So ADHD typically needs to be assessed through observation in the assessment room, as well as at home or at school or at work, depending on the age of the person who's coming in. But I will go through a few of these assessments with you just so that you know some of them. So there are specific behavioral rating scales, such as the Behavioral Assessment System for Children, which is oftentimes just called the BASC, as well as the Achenbach system for empirically based assessments. And these can be used as screening devices to identify possible ADHD problems among a number of other behavioral problems. And both of these instruments can be helpful in identifying children in need of further assessment, but they should not be relied on as the basis for diagnosing ADHD. We do have some more specific scales, such as the Conners rating systems that are advised. We have the DSM symptoms scales, the ADHD reading scale, and all of those focus on, and the Barkley screening checklist. And all of these are focused specifically on ADHD symptoms among children. We also have the Adult Attention Deficit Disorders Evaluation Scale, the Conners Adult Rating Scales, and the Brown Adult ADHD Rating Scales that are all instruments that may be used to assess symptoms amongst adults. So you can see here that we have these sort of scales that can be used to help inform an ADHD diagnosis, but are almost never independently what we use to diagnose someone with ADHD. And again, similar to other categories, we have some that are more specific to children, some that are specific to adults, and some that are more specific to behaviors amongst many presenting concerns. And overall, the scales that we've discussed here for ADHD should be used with caution because research shows that ADHD checklists, a lot like the ones that are listed here, the one that are not like the ones listed here, are much better at identifying ADHD than broadband scales like the ones that are listed here. So that is going to wrap up our conversation on Chapter 8. And as always, here are the questions for review to help you make sure that you're understanding the content from this lecture. And I will see you all in the next lecture.